So cerebral palsy is the static encephalopathy. That is, it is a non-progressive damage that occurs to a developing brain that causes cerebral palsy. So what happens? There will be motor disabilities, that is abnormality in tone, posture, movement. Okay. So it is the cause for the most common chronic motor disability in childhood. It can present with or without intellectual disability. Then the manifestations evolve over a period of time. Then the incidence is 2 to 3 infants per thousand live birth. Now coming to the etiology. Etiology, there are mainly three factors, that is prenatal factors, perinatal factors, and postnatal factors. In prenatal factors, it mostly includes genetic disorders, inborn errors of metabolism, brain malformations, congenital or intrauterine infections, for example, toxins or torch infections, teratogens, maternal or obstetric complications. In perinatal causes, it includes birth asphyxia, prematurity, low birth weight, birth trauma that can cause intracranial hemorrhage. Then mini neonatal stuff, neonatal infection, neonatal seizures, neonatal hypoglycemia, neonatal hyperbilirubinemia. Then the postnatal causes include infections of the central nervous system, hypoxia, trauma, drugs, toxins, metabolic disorders, etc. Now, what are the comorbidities of cerebral palsy? The comorbidities include intellectual disability, microcephaly, seizures. Okay, let's arrange it in a order from head to toe. So, from head, there is intellectual disability, microcephaly, CNS problems like seizures, contractures. Okay, now coming to eyes, blindness, squint, then coming to ears, deafness, then coming to mouth, difficulty in speech, language, so similarly swallowing and feeding, so malnutrition, excessive drooling, etc. So these are the complications. Now coming to the classification, there are mainly two classifications. One is topographical classification that includes quadriplegic, hemiplegic, monoplegic or diplegic, and physiological classifications that include spastic, dyskinetic, ataxic or mixed. So now there are mainly four classifications. First one is spastic, and under spastic, there is topographical classification that is diplegic, hemiplegic, quadriplegic. Then other three classifications include dyskinetic, ataxic, and mixed. So in spastic, there are three under topographic classification. These three include diplegia, hemiplegia, quadriplegia. Diplegia means lower limbs are affected. It is mostly seen in preterm babies and as a reason due to periventricular leukomalacia. That is the lateral white matter around lateral ventricles are affected during preterm. Okay, so here intellectual disability is uncommon. Then comes hemiplegia. Hemiplegia means only one side of the body is affected. It is mostly seen in neonates as a sequel of neonatal stroke. Then quadriplegia, all four limbs are affected. Birth asphyxia, it is due to birth asphyxia of term babies. This quadriplegia is very important. It is most common in India and it is the most common spastic type of cerebral palsy. Then it is due to parasitated infection. Here intellectual abilities disability is common. Here hemiplegia, it can be preserved or it can be affected. In diplegia, it is mostly preserved. So there are mainly four classifications: spastic, dyskinetic, ataxic, and mixed according to physiological classification. And under spastic, there is a topographical classification of diplegia, hemiplegia, quadriplegia. So with that, spastic is over. Next is dyskinetic. Dyskinetic, or otherwise called as chorioathetoid cerebral palsy. Here it is dyskinesia is due to abnormal movements of limbs due to damage to basal ganglia. This basal ganglia damage can occur either due to asphyxia or increase in level of jaundice that can cause kernicterus, that is increase in high levels of unconjugated bilirubin can cross blood-brain barrier and deposit in basal ganglia. So basal ganglia is usually responsible for smooth coordinated movements and prevents unnecessary movements. So and helps to maintain normal muscle tone. So when there is damage to basal ganglia, there is chorioathetoid or extrapyramidal movements. That is second type. Here also intellect is relatively preserved. Next comes ataxic. Ataxic cerebral palsy is there when there is damage to cerebellum vermis, and that is causing dysfunction. that is, the cerebellum is responsible for balance, coordination, precision, and timing of movements. So when there is damage to cerebellar vermis, there will be ataxic movements. Then mixed cerebral palsy, that is combination of spastic, dyskinetic, and ataxic. Now, what are the clinical presentations of cerebral palsy? First one, there will be global developmental delay. When do we say that there is global developmental delay? There is delay in at least two domains of milestones. Out of gross motor, fine motor, language, and social, there should be delay in at least two milestones. Then there is persistence of neonatal reflexes. There are some reflexes in neonates that are supposed to be it's supposed to disappear after a certain period of time. For example, Moro's reflex is supposed to disappear after 4 months, 4 to 6 months. If there is persistence of Moro's reflex, it's a clinical presentation of cerebral palsy. That is due to the brain is still immature, so the neonatal reflexes still persist. So what is Moro's reflex? That is, there will be abduction of arms when we are first keeping the baby in supine position and leaving the baby's head by around 20 to 30 degree behind backwards without support. There will be sudden abduction of arms and followed by crying. So if that persists beyond 6 months, it is called as persistence of neonatal reflex. Then third clinical feature is spasticity. It includes three main under spasticity, there are mainly three features. Scissoring posture, as you can see in this figure, that is due to increased in tone of adductors of lower limb. Then toe walking. Even adults can walk in toes, but that is a voluntary action. When there is an involuntary toe walking always, then we can consider it as a feature. Then cortical thumb, as you can see in this figure, there's thumb in a fixed posture. This is common in small children, but if it is persisting beyond 4 months, it can be a clinical features. Then vision abnormalities, hearing abnormalities, abnormal posture and gait, abnormal movements or hyperflexion. All these are example. Now management. So we need a multidisciplinary management. We need the help of social workers, occupational therapists, speech therapists, specialist teachers, etc., ophthalmologists, etc. So MRI brain is the investigation of choice, and the treatment includes symptomatic with multidisciplinary approach. So because it is irreversible in nature. For seizures, we have to treat with antiepileptics. For spasticity, we can use muscle relaxants such as baclofen. Contractures, we can use tendon release procedures. And dystonia dyskinesia, we can use levodopa.